Hello, everyone. Are you ready? We hope you're enjoying the beautiful weather in Seattle. And we're so excited to be able to talk with you today about addressing current questions and controversies in the care of patients with ovarian cancer. My name is Angeles Alvarez Secord, and I'm so fortunate to be up here with three incredible individuals who are not just tapping and breaking some glass ceilings, they're shattering them. And our first speaker of today will be Dr. Shannon Westin, followed by me, and then Dr. Kathleen Moore and Dr. Ritu Salani. And so we're really excited to share some of this data with you, as well as discussing how we care for our patients. Shown here are all our disclosures. This activity is supported through educational grants from AbbVie, AstraZeneca, Daiichi, Sankyo, Merck, and Mural Oncology. And I'd like to also thank all of the Research to Practice CME Planning Committee members, the amazing staff that has helped us put this together, and all the reviewers for this content we're going to share with you. So this educational activity contains discussion of non-FDA approved uses of agents and regimens. Please refer to official prescribing information for each product for the approved indications. Okay, well, what about what you all want to know? What clinicians want to know addressing current questions and controversies in the care of patients with ovarian cancer? The field is moving so quickly. It's incredibly impressive how fast the landscape is always changing. And I've already mentioned our esteemed faculty, of which two, Dr. Salani and Dr. Westin, are our graduating GOG scholars who've done incredible work and going to share some data with you today. All right, here's our agenda. Module 1 will be presented by Dr. Westin, upfront treatment for advanced ovarian cancer. Module 2 will be me, management of relapsed refractory ovarian cancer. Module 3, Dr. Moore, novel investigational therapies for advanced ovarian cancer. And Module 4, Dr. Salani with diagnosis and management of adverse events associated with commonly employed therapies for advanced ovarian cancer patients. And we all know each other really well, so we're going to go on a first name basis. So Shannon, Angeles, Katie, Ritu. All right, that's really fast talking there. So some of the questions we want to share with you are actually surveys from gynecologists and general medical oncologists that they shared with us, and we're going to share with you as we go through this discussion. Results for these surveys are available on the iPads and the Zoom chat room. You ready, Dr. Westin?
Oh yeah,
Let's
do it.
Upfront treatment of relapsed and refractory ovarian cancer.
Thank you, Angeles. Okay. So we've got just 10 minutes to cover quite a bit of data, so I'm not going to rehash a lot of what I hope you all already know about upfront maintenance in advanced ovarian cancer, but instead talk about some of the newer data that have come across our desks over the last few months. But just to level set and make sure we're all on the same page, these are the most recent NCCN guidelines. The bottom line here is, especially for those patients that have a biomarker, whether that be BRCA mutation in the tumor or hereditary BRCA mutation, or in those patients that have homologous recombination deficient test positive disease, the standard of care is PARP with or without bevacizumab. And I just want to put that out there and level set because now we have a number of different options and strategies that are available to us in that space. And so how can we decide and what data can we use to help us make those decisions? So first, let's talk about SOLO 1. You all are very familiar with this trial, and Dr. Moore is here, Katie is here and can certainly provide insight, but this was a newly diagnosed group of patients that all had a BRCA1 mutation. And again, it could be either germline or somatic, although the majority of the patients had germline mutations. They were randomized to olaparib in the maintenance setting for 2 years versus placebo. And we've seen the earlier data, very clear benefit in progression-free survival, as well as updated progression-free survival. And then, these are the data that are kind of most recent around clearly a sustained progression-free survival benefit with reduction in the risk of progression. You can see that beautiful tail of the curve completely flattening out. And we see that replicated on the overall survival curves as well. And I put here, we still haven't gotten to the number of events that would trigger the analytic endpoint for overall survival, but surely we're out past 7 years now. We can feel very comfortable that this is not detrimental and is potentially the best thing that we can do for this patient population. Now, that's a BRCA mutant population. Prima was looking at niraparib, and this was in an all-comers population. Again, they tried to kind of tease out a so-called more high-risk group, although all patients with advanced ovarian cancer are high risk. I think we would all agree on that. But this was a population that had newly diagnosed ovarian cancer, had some type of benefit, either CR or PR to chemotherapy, and then either had neoadjuvant chemotherapy or residual disease, and then were randomized to niraparib versus placebo. We've seen the data around progression-free survival. Early progression-free survival was clearly beneficial in the population that had biomarkers, the HRD test positive, and was positive in the overall population. We did see sustained benefit across all the populations, but you can see the tails of the curves start to meet in that HRD test negative group. So giving us an indication that the biomarkers certainly do matter in this population. And then most recently, we saw these overall survival data, and sadly, we did not see a benefit in overall survival, and that was across all the populations. You can see starting on the left of your screen, the overall population, no clear benefit, no detriment either. And then moving across, we didn't see as much separation in the populations that have the biomarker. We didn't see as much separation in the HRD test positive group or in the BRCA mutant population that we would expect. So we can talk about this. I think Angeles is going to lead a nice discussion. We can talk about why we might postulate that has occurred. And then finally, PAOLA-1. So this is olaparib and bevacizumab. Again, this was a population that enrolled after response to therapy. So it's a little bit different on the timeline, and I have a slide that kind of helps us compare these different trials. But you can see that patients had a benefit to chemotherapy, and they all received bevacizumab. And then they were randomized at the completion of chemotherapy to either continuing the bevacizumab alone or adding the olaparib. And of course, this yielded FDA approval in the populations with HRD test positive or BRCA mutant disease. And this is based on prolonged progression-free survival effect, where we see a reduction in the risk of progression of about 60% across both of these biomarker positive populations. And then importantly, we see a really nice overall survival benefit in this same biomarker positive population. So a clear reduction in the risk of death in those patients that were treated with olaparib and bevacizumab across that group. So we've got 3 drugs that are FDA approved in this space, or combinations. Like, how do we decide? How do we choose? And I unfortunately don't have enough time to go through each one of these potentials in detail, but of course, where is our indication? Who's the patient in front of us? What are the biomarkers that we see? Do we use BRCA and HRD? And I think, now that we're starting to see some of the overall survival data, the long-term progression-free survival data, we can use that to inform our choices. Did we use bevacizumab from the beginning? That matters, right? If you've started bevacizumab, we generally are going to continue it. And then there's a little bit of data coming out around how response to therapy or certain clinical characteristics might help us guide our choice here. And then, of course, things like toxicity, schedule, and price. I think toxicity is obviously a big concern for our patients in addition to the patient-reported outcomes, and this is just a snapshot across these 3 major trials. You can see that in general, the majority of patients are going to have some adverse event, but those grade 3 adverse events, the ones that potentially can lead us to dose interruptions and dose reductions, those are a little bit differential with higher levels of thrombocytopenia in PAOLA-1 versus anemia in, thrombocytopenia in PRIMA versus anemia in the agents that contain olaparib. But running down, and I know that Ritu is going to speak about this as well, when we talk about AML and MDS, we see very, very low rates in the upfront setting, which is very reassuring. Now, do we have any ability to compare some of these trials? I know, I don't know if Rob Coleman's here, and we don't like to do cross-trial comparisons, but these are some interesting population and adjusted indirect comparisons of some of the studies, and you can see on the left a study population comparing similar populations between SOLO-1 and PAOLA-1. you start to see that differential effect, and potentially the group that gets the combination of olaparib and bev does a little bit better. You have to be a little bit cautious. And then similarly on the right, in a comparison of PAOLA-1 and PRIMA, again, you're getting that combination strategy that for potentially a patient, there's a population for whom you want to do all the things. And then this is just a note I think is kind of interesting. We've seen this in the platinum-sensitive setting. We've seen this in the platinum-resistant setting. When we add bevacizumab to chemo, we potentially can see increased response to therapy, and then that can potentially allow a patient to stay on maintenance longer. And so we do have some data that potentially the combination of olaparib with bevacizumab could give us more responses, and specifically more complete responses, and potentially that can help us with symptoms and keeping patients on study. So what about the trials that have just been presented? And I'm just going to take a quick minute to talk about those. What about these combinations of adding immunotherapy to PARP, immunotherapy to BEV? And we've got some mechanism of action here where with the patient population and the tumors that have homologous recombination defects, we see a higher neoantigen load, a higher number of tumor-infiltrating lymphocytes. And conversely, when we treat patients with PARP inhibitors, we see an increase in DNA fragments, which then stimulates what's called a sting response, which stimulates the immune system. And there's some xenograft data and models to support that. But has that been borne out in the data? Well, we're eagerly anticipating the results of the first trial, which I hope will be the definitive trial in this space, where patients were randomized to chemotherapy. Bevacizumab was investigator's choice, but you can see the arms here this is a PARP study. So we're starting with an arm that adds niraparib, and then the second or the third arm adds dostarlimab to niraparib. And so hopefully we'll get an idea of what IO adds to PARP, which is our standard of care. The trial, and of course we have seen the press release that this did meet its primary endpoint. We'll see what that really looks like in the data once this is presented. But of the two trials that have been reported prior to first, we have DUO-O, which again is chemo, and they were required to get bevacizumab, so everyone gets chemo and bev, and then they were randomized to either receive durvalumab or durvalumab and olaparib with a progression-free survival endpoint. And of course, it did meet its primary endpoint of progression-free survival in that arm 3, the quadruplet arm, as opposed to the chemotherapy and bev alone arm, but we're missing a PARP arm here, right? So we don't really know the contribution of components, and it makes it a little bit hard to implement it in practice. And so again, when we tease out the different populations by biomarker, either HRD test positive, HRD test negative, we see that arm with the PARP and the durvalumab doing well, but we don't have that bev PARP arm in this study. And then at ESGO, as well as here at SGO, we saw the KeyLink data, which is with pembrolizumab and olaparib. And in this study, bevacizumab was optional, so again, investigator's choice. You saw these data just yesterday in a group of patients that selected for the checkpoint, so CPS positive greater than 10, we saw a benefit to the combination of pembrolizumab and olaparib based on progression-free survival. And we saw that slightly in the intent to treat population, but again, we're missing that arm that tells us the contribution of the olaparib versus the contribution of the immune checkpoint with the PARP inhibitor. And then this is my last slide, and this is modified from my friend Katie. I think sometimes you can look at these data and be like, oh, this is so much better. Like, look at these curves. That curve from DUO-O is in the HRD test negative group is so much better than what we see in the HRD test negative group in PAOLA-1. But in fact, when you consider when they started randomization and when they started therapy, you're not comparing apples to apples. And in fact, the curves are a little bit closer to overlap if you start according to when the drugs were started. And then, of course, this is the forest plot from the recently presented KeyLink study, which indicates that potentially if you massage these data in a way, or beat the data, or whatever you want to call it, that, if it's LOH low, HRD's test negative, they didn't get bevacizumab, okay, that's the population that potentially can benefit. You have to be super careful with this because these numbers are small and it's really hard to define that population that might benefit. So I will stop there and let my fabulous moderator take over.
Yes, well, that was a fabulous presentation. Thank you, Shannon.
Thanks.
I want to start off with what Shannon just ended with, which was this huge review of very important studies, but also the value of adding immunotherapy. And so we wanted to just pop off with this first question here. So regulatory and reimbursement issues aside, which patients, if any, would you treat in the primary setting with carboplatin and paclitaxel plus the PARP inhibitor, plus IO, plus bevacizumab, which is the quintuplet, if you will. So Shannon, which patients would you treat?
None of them. No, so I just don't think we have the data at this point. We're missing the contribution of components. And I'm not judging the study designs because we all do the best we can when we're putting these studies together based on the existing standard of care. But unfortunately, we really can't interpret the Duo and Keylink 001 studies in this setting at this point. I'm hopeful first will give us a more definitive answer, but at this point, this is not something I'm offering to patients.
Katie?
I do not disagree with that. I would be adding immunotherapy only in a mismatch repair deficient or MSI high ovarian tumor, which exists, but they're incredibly rare. But that would be the only setting at this point.
Ritu?
I totally agree. I don't think there's a role, and hopefully we'll get some more information from the first trial, but at this point, no role.
Okay, this is really amazing. I think for the first time ever on a panel, we have 100% consensus. So, wow, that's awesome. All right, let's go on to the next one. How do you sequence your biomarker testing to be logistically and economically sound? Do you send germline testing, then HRD, then NGS, or do you just use NGS directly? Anyone?
Yeah, I'll start. We do NGS typically on the original tumor, and we do germline testing as well. Maybe not the most economical, but it does give us information that we're able to use through the life cycle of the ovarian cancer journey.
What about you, Katie?
I mean, I think we're just going to agree with one another.
my gosh.
I mean, I'm not known for my economic soundness in practice. I like to send things. So I send both. I think most of my partners do as well. We're sending NGS right out of the gates on any advanced tumors, as well as germline. So we really know what we are kind of up against and can plan our treatment and mainly our maintenance strategy up front.
Can I add to that quickly, or do you want to
Yeah,
go, Shannon?
go.
I was going to say, we also get IHC on some of those too, and so we have information about alpha folate status, we have information on HER2 status. We get that also at the time of diagnosis because it's offered with these commercial assays. So I agree, it's not maybe something I'm using now, but it's something I can use for the future.
Yeah.
You're doing the same, Shannon?
Yeah, I mean, I think in general, I do think it's reasonable to start with the hereditary testing and then trigger the subsequent HRD and NGS, especially in the population where you're maybe doing neoadjuvant and you don't have a ton of tissue. Because sometimes if you send some of the, especially for HRD testing, if you send too little tissue, you'll often get an inconclusive result and then you're having to get it retested. So, I do think that starting with the germline strategy isn't terrible. I do hesitate to just do next-gen sequencing and just do somatic testing because you will miss a proportion of patients that have a BRCA germline mutation, about 5% probably, which really matters, right? It matters not only from the treatment standpoint, but it matters on prevention of future cancers and that patient's family. So I do think that you could potentially consider just the germline to start.
Yeah, I do germline and HRD. I don't do NGS off the bat, so we don't quite have consensus, but it's all good. It's all good. All right. So Shannon, which maintenance approach would you recommend for a patient with germline PALB2 mutation? Do you treat these essentially equivalent to a BRCA mutation?
I 100% treat these equivalent to BRCA. I think this is one of the mutations that we have fairly great data to indicate that it is potentially predictive of response to PARP. Nothing's perfect, of course, but this is a population for whom I think they deserve PARP inhibitor, at least with or without BEV.
All right, this is a case. So let's talk about a 47-year-old patient with stage 3 ovarian cancer who underwent optimal debulking, then carboplatin and paclitaxel times 6. Germline and somatic testing returns negative for BRCA alterations, but is positive for HRD. Given OS data from Paula versus Prima, what is the optimal maintenance strategy? Katie, I'm going to give this one to you. How would you treat her? Niraparib or start her on bevacizumab so you can give her olaparib, or do you assume that the OS in Paula was driven by olaparib and give olaparib alone?
Well, I wish olaparib alone monotherapy, that's redundant. I wish olaparib monotherapy were on label. It's so silly it's not. It really comes down to sort of the patient and my decisions around chemotherapy. I actually really like the KELM scoring as well. I kind of layer that onto my decisions as to whether I'm going to use bevacizumab. That's controversial, I know. But I sort of make the decision for bevacizumab, and it sounds like here, if I'm treating her and I didn't start bevacizumab during this point, then I had made that decision, and I'm just going to use monotherapy PARP inhibitor, which would be niraparib on label. If I'm getting her as a consult at this point, then I'm going to look back at the response to chemotherapy, what the CA-125 trajectory was, and kind of figure out how worried I am, which is not very scientific. And then I might add bevacizumab and do a Paula-based regimen or not, but it sort of depends on where I encounter this patient in her journey.
Got it. All right, audience, I'm going to do an audience question without the poll. So there's no right or wrong answer here. Wondering, how many of you utilize bevacizumab in a frontline setting for all your patients, or in a selective manner? Do you use bev, yes or no? All right. All right, and then switch it. How about no, you don't use bev? All right, very interesting. I don't use hardly any bev, but yeah, all right, just want to throw that out there. Let's go to the next one. 49-year-old female with stage 3 clear cell ovarian cancer who has BRC, she does not have a mutation, and HRD is negative. She completed 6 cycles of chemotherapy plus bev. What would you recommend as a maintenance therapy? Would you recommend PARP inhibitor in an HRD negative patient, or are there subsets of HRD negative patients who you believe benefit from PARP maintenance, such as those patients who are suboptimally cytoreduced or stage 4? And Ritu, I'm going to hand this one to you.
Sure. So always challenging situations. I do like bevacizumab for these patients. There's some retrospective data, so I do typically incorporate that for these patients with clear cell. I would also want to check her MMR status, MSI status, TMB status, just to make sure there's not a signal there, because oftentimes these can look more like endometrial type cancers, endometrioid or clear cell. So I would also check that. I can't say that PARP is, I'm enthusiastic about PARP. I probably have a discussion with the patient, but I would generally favor bevacizumab.
All right.
Can I say one thing?
Yeah.
I think for this, I totally agree with that. I think bevacizumab in a clear cell is what I would pick. But I would also add to the things you said. We want to make sure that we're testing HER2 in IHC, and I would honestly test for folate as well, but definitely HER2, because there was a study that was just activated. And these, as we all know, these patients are so high risk for early progression. Knowing that upfront would be really helpful.
I agree. That's like a perfect segue into our next talk. All right, we're going to talk a little bit about management of relapsed and refractory ovarian cancer. And I just wanted to throw this out there as a call for action. In 2020, when this data came out and I accessed it in May of 2022, these are patients around the world that have ovarian cancer, over 310,000 cases, and that is anticipated to rise over 400,000. So even though some of the numbers look better in the US, I don't think we can sit on that. I think we still need to work hard to find prevention strategies. So in this module, we're going to talk about the prevalence and clinical relevance of BRCA alterations, HRD, FR alpha, and HER2 status, review the clinical utility of some of the therapies that treat or are targeted toward these different biomarkers, and then summarize the current landscape. And this is just a short preview of everything that Shannon took us forward. And really, PARP inhibitors changed the world. And Katie actually changed the world with, I think it was 2014, some of the work was done. And then Solo was at 2018. And then 2019 was when all these studies came out. The landscape has changed. We just talked about IO therapy. We're not going to go there right now. And then I love this slide. It's been used a lot. I think it's really beautiful in terms of the colors. But the main point here is that BRCA mutations are fairly common in this patient population. And about 50% of patients will have HRD tumors. So this has really profound implications in terms of utilization of PARP inhibitors. What about FR alpha testing? This is an amazing biomarker story, and really give a lot of kudos to Katie. I've said it to you before. She can share that story with you sometime. But PS2 positive scoring versus 10x scoring versus TPS scoring. Sometimes keeping it more simple is not better, and PS2 plus scoring is really how we evaluate this. And that's based on the intensity and percentage of cells scored. So FR alpha expression is really high in ovarian cancers. It's like 80 to 90%, but in terms of high levels, it typically ranges from 35 to 40%. And when you get a report, these are just some reports that I had received, one of the patients has really strong FR alpha staining, you can see in that red box there, and it's 100%. The bottom one says FR alpha is negative, but in actuality, there is some positivity there. It's just low level. So I think we're going to get to a point where it may say FR alpha positive and give a percentage. And then FR alpha expression has been associated with worse outcomes in some studies, but there is some controversy there. What about HER2 scoring? That is a rabbit hole. I had no idea how challenging this was. The point here is that the HER2 positivity is very high in mucinous carcinomas, and then can be higher in some of these other cancers. And it depends on what publication you read. It has also been associated with outcomes. And one of the first studies, led by Dr. Michael Bookman, I don't know if he's in the room, was GOG 160, which evaluated trastuzumab, which targets HER2, and the objective response rate was only 7.3%. But I think there's a lot of things we didn't quite do right in that study. And one of the really challenging things with HER2 is the number of different scoring methodologies, and also there's not one candidate biomarker other than one company for like ultra low, and when trastuzumab first came out in breast cancer. So there's a lot of different antibodies that your pathologist may be using. There's a lot of different scoring methods. All right, this is just some standardized reporting that came out in 2023 to coincide with the updated ASCO and ESMO updates and consensus statements. And now there's not just 0, 1 plus, 2 plus, 3 plus, but there's also this category called ultra low that you may hear about. 3 plus is the amount of immunostaining that you would see on gastric scoring that led to the approval of trastuzumab deruxtecan. And then in the NCCN guidelines, it allows for the use of that agent in patients who have tumors with 2 plus HER2 expression. So Katie gave me this slide set, and I thought it was really interesting. It's about HER2 expression, which is higher in mucinous and clear cell cancers, and goes to the point that she was just making in doing the IHC testing for those patients. And it's lower in patients who have the serous cancer types. And I think, Katie, you're going to talk a little about this as well, so I won't belabor it. But what I really wanted to show here is that in FR high tumors, defined as those with greater than 75% staining, there's really minimal overlap with HER2 positivity defined as 3 plus. But when you take that group of patients that have cancers with HER2 3 plus, over half of them will have high FR alpha staining. And this has implications when you're trying to decide about sequencing therapy. All right, and this testing, when you evaluate the HER2 levels and outcomes, you can see where the most pronounced findings are in patients who have a high-grade serous or high-grade endometrioid cancers. And that middle, right there, you can see that patients who have HER2 2 plus or 3 plus staining have much worse survival outcomes compared to the other patients. And what's really exciting here is that you're able to help these patients who need it the most with drugs that target HER2. So let's talk a little bit about NCCN guidelines, because PARP inhibitor therapy can be somewhat challenging in terms of patients who have platinum-sensitive ovarian cancer who've never had a PARP inhibitor anymore. We don't see those patients a lot anymore because a lot of these patients are getting PARP up front. So what are the guidelines there? So if you have a patient who has platinum-sensitive ovarian cancer and they've never been treated with a PARP inhibitor therapy, then the guidelines do say, if not previously used, category 1, consider use. Or if the disease had not progressed during a prior PARP inhibitor therapy, you could also consider it for those patients too. So previously treated, did not progress during PARP, and maybe once their treatment was done, they progressed later. NCCN guidelines for platinum-sensitive ovarian cancer, there were a few changes. If you look under the targeted therapy, they added mirvetuximab soravtansine for patients who have platinum-sensitive disease and greater than or equal to 75% level. And I believe this one was there before with the MIRV and the BEV, and that is at 20, or is it 50%, greater than or equal to 50% there. The trastuzumab deruxtecan, we've talked about already, is for 2+ and 3+. But what's really interesting here and important to note is the use of single agent PARP inhibitor therapy is category 3, which means there is some major disagreement when they came up with these guidelines. And still the preferred regimen in patients with platinum-sensitive disease is going to be platinum doublets. What about platinum-resistant disease? A lot more options here than we ever had before. Under preferred regimens, we have the single-agent cytotoxic therapies with or without Bev, and then also this is from previous mirvetuximab for those patients with high expression, and also Bev as a single agent. I don't think Bev is really commonly used as a single agent anymore, but we can talk about that. PARP inhibitors as single agents here is category 3. And then we have mirvetuximab with Bev, but a little different than platinum sensitive. It's in the greater than or equal to 25% expression. And we have trastuzumab deruxtecan, as previously mentioned. So the top part here is just from the LIGHT trial. It's the updated analysis. And I just really don't think this is as relevant anymore, but I wanted to build this into PARP combinations. And what you can see from this top graph here is that in select patients who were never previously treated with a PARP inhibitor, there did appear to be some benefit in terms of response and survival. However, and there's a lot of interest in evaluating combinations, and we were really sad about the outcomes of the study where we combined olaparib with cediranib, and GY004 evaluated either that combination or olaparib alone versus standard of care chemotherapy, and the study did not meet its endpoint. It was not superior to chemotherapy. You do see that there is activity in that BRCA1 and 2 mutation group here. This is the olaparib only group, and they actually, or this was olaparib cediranib, and it was about 18 months PFS here. So there is activity. It may be beneficial for some patients, but it didn't reach the bar that was placed in the study. And then GY005 was conducted in patients with platinum-resistant disease. 4 arms starting out, 1 arm was dropped. That was the olaparib arm, and unfortunately was not superior to chemotherapy. And I know that Shannon's doing a lot of great work evaluating olaparib combinations. I'm just going to get a shout out for a combo match. So mirvetuximab, as I mentioned before, is really a beautiful biomarker story, and I wish we had more time to share it with you. I hope you write that up someday, Katie, because it's really, really cool. But I'll just give you that teaser. So mirvetuximab received accelerated approval based on the SORAYA trial with a response rate of 32% in patients with platinum-resistant ovarian cancer, which is outstanding compared to what we typically quote for these patients in clinic. That led to MIRASOL, which was the phase 3 trial. And what you can see here is that in the MIRASOL trial is that mirvetuximab really is a quadruple threat. It improved survival outcomes. It improved disease control based on PFS. You had higher response rates. It was 42% versus 16%. I thought this was awesome that in a phase 3 study, you actually saw higher response rates. And then not only that, you have a benefit of quality of life. This was some Q-TWIST data that was recently presented, and the twist time actually was longer with mirvetuximab compared with standard of care chemotherapy, meaning that there was a longer time without intervening symptoms or toxicity, and the toxicity score was less with mirvetuximab. So it's a really favorable agent. What about in your older patients? Sometimes I get worried about treating older patients. Patients did really well in the study when they were older as well. And then the PICCOLO study was a very interesting study. It was a single-arm study of mirvetuximab in patients with platinum-sensitive disease who had greater than or equal to 75% scoring for FR alpha. And this was a heavily pretreated group of 40% or close to 40% had 3 or more regimens. 81% had been previously treated with a PARP, and here's a really important aspect: 75% had progressed on a PARP. And when you look at the waterfall plots, you see this really deep. And I love this waterfall plot because essentially almost every patient benefited from being on the study except 2. And the response rate was 52%, with 7.6% having a CR. And the duration of response was slightly over 8 months. And this is data by subgroups. And what's really interesting here is that in the patients who had a BRCA mutation or were PARP naive, the response rates were over 70%. And patients who progressed on PARP, the response rate was closer to 46%. So patients who've been previously treated with PARP, they're not the same as the patients in the past, and they may not respond to therapy as well. And for the patients that did respond, that duration of response was still in the about 8-month range. All right, Gloriosa is currently ongoing, evaluating mirvetuximab with bevacizumab versus Bev in the maintenance setting. And we have that study open. I'm really excited about it. I'm not going to belabor these too much, but there's other drugs in this area. Leveltabimab is also targeting FR alpha, but may have activity at lower percentage of expression. Rena-S has also pretty pronounced activity with, at the higher dosing levels, a 50% response rate. And that activity may also be present in patients with lower level FR alpha. HER2, I think you've seen this slide probably 50 times already. Just not going to belabor it, but response rates were pretty outstanding. Patients with HER2 3+ disease had 64% response rate. So testing is critical. FR alpha and HER2 testing should be done. It helps lead how you're going to treat patients. And combo match is currently ongoing, as well as all these different trials, and I think Katie's going to talk about them as well. So, questions. So, what are the current indications for PARP inhibitors in the recurrent setting? And what about in patients with a long disease-free interval after a previous PARP, like 4 or 5 years? Should we consider retreating after second-line chemotherapy? So, I'll just see, anyone want to take that one? I know I went over it really quickly in terms of some of the NCCN guidelines.
I can start. So, current indications for PARP inhibitor in the recurrent setting are only for platinum-sensitive maintenance and BRCA-associated cancers. All other indications for PARP inhibitor have been retracted by the FDA because of concerns for detriment to overall survival, which is something we can spend an hour discussing. So that's the current indication. That being said, would you ever consider reuse of a PARP? I actually would say yes to this. It had designed a study that was hopefully going to study it, and it's not going to go. But sadness. But you know, if you had a patient who had a BRCA mutation that received a PARP inhibitor for 2 years, and you can see late recurrences. If you have 3 or 4 years later, if someone recurs, there's the question of reoperation, and then reinduction with platinum-based chemotherapy. And then I would absolutely consider reuse of a PARP inhibitor in that setting, but it would also be doing all the rest of the biomarker testing for folate and HER2 and reversion mutation testing, which is unlikely if she's still this platinum sensitive, to really try to optimize the regimen that I used. And I wouldn't use it for forever. I wouldn't use it as it was studied, you know, as treatment for forever. I would use it for a time-limited amount of time that I would make up because there's no data.
Like 1 or 2 years.
I might use 2 or 3, but I would make it up.
All right. This is a really important point. I think this next question, do you test for FR alpha in the archival tissue, or do you do a new biopsy? I mean, Katie, you're kind of talking about looking for reversion mutations, so maybe you like to do a new biopsy. Any thoughts from the group about when you test and what you test?
Yeah, I can start. We often get it at the time of diagnosis just because it's part of the panel. When we order our NGS, you can get the IHC. If we don't have it at that time, we send it out. We don't do it in-house, alpha-folate receptor testing, so we use neogenomics testing that's done. And if we can always get a fresh biopsy, we prefer that. So that is our preferred option, but we don't necessarily mandate it, especially if there's a short interval from the primary to now. Or if you can't get a biopsy, we'll use archival tissue.
Shannon, what do you think about mirvetuximab in patients that don't have FR alpha that's greater than or equal to 75% expression?
I mean, I think you flashed the data quickly around, this level was very carefully selected and is what led to the FDA approval. With that being said, we do have some intriguing data around using mirvetuximab in a lower FR alpha positive group, potentially with the addition of bevacizumab, and that is compendium listed. I think some of the other newer FR alpha drugs will be really interesting here because we are seeing them use levels that are a lot lower, some all comers, some 25% or more. So there is a potential to kind of expand beyond that 75%. But I think that was very carefully chosen after extensive years of study by my friend next to me.
Yeah, Katie, you want to elaborate?
I mean, I don't disagree with that. It is NCCN listed with bevacizumab for FR alpha expressing tumors, and I think that's worth considering. I know we didn't have time, but we did in Forward 1, because there was a bit of a debacle with the biomarker, go back and rescore as to the current scoring. And so we have a population of folate low, which is 25% to 50, medium, which is 50 to 75, and then high, MIRV versus chemo. And for the high, it clearly wins. For the medium, it's maybe a little bit better, and so it's a very reasonable consideration. For the low, it wasn't better than investigator's choice, but it still has activity. And so it helps you. I would consider it, but it would be how I would sequence it with other things, particularly weekly paclitaxel. Like I would use that before or after based on my expectations of benefit. So I think that we have that data that helps us use it in the right order.
Yeah. And I think what's really cool is you actually had to go back, reassess all those tumors utilizing the different scoring system. And that's where you demonstrated, yes, this drug does work. So
Right.
I just think that's super cool. All right. So in what line do you, just really quickly, I'm going to go through the whole group here. What line do you typically use mirvetuximab? We'll start with Ritu.
You know, when patients are platinum resistant and they have high alpha folate receptor expression, it's oftentimes, it's my treatment of choice in those patients. So it's, 1 to 3 prior lines, I'm using it.
Katie?
Same. I mean, I think it beat all of the subgroups. So
Second time consensus.
Yeah.
Wow.
yeah.
As soon as I get a hold of them.
Awesome. Okay, so we talked a little bit about MIRV with BEV. And some people are saying, well, I'm just going to do MIRV and BEV because, combine both of them, it'll work better. Are there any, so in a patient who has FR alpha 75% or higher, would you add mirvetuximab or would you add bevacizumab to mirvetuximab?
I mean, I can start. I generally don't because there's a population that doesn't need bevacizumab. And so I want to see if that patient can get benefit from the mirvetuximab alone. I mean, I think maybe if there was clinical features like extensive ascites and I wanted to see if I could dry that up with the bevacizumab, I might add it at that point before I gave them a trial of the MIRV alone. But I'm pretty reserved with my use of bevacizumab with MIRV.
All right. So the other one I think we already kind of answered in terms of the different expression levels. I want to talk a little bit about MIRV and platinum-sensitive disease. Has the PICCOLO study changed how you treat patients with platinum-sensitive disease?
Heck yeah. I did want to just say I'm very conflicted because I've been involved with MIRV for a long time. So I just want to say that to the audience. So take what I say with a grain of salt because I sometimes can't control myself. And I mean that honestly. I've been involved since 2012, and so even though I try to be balanced, sometimes I'm not. But in a first very platinum-sensitive tumor, no, I'm going to use platinum. But we all have these patients and that's who was tested on PICCOLO. They had to have at least 2 platinums. And the patients that I enrolled on that study were it was like their 4th platinum-sensitive regimen. And platinum doesn't work incredibly well there, or they've had allergies, or all the things that make you kind of meh about using platinum again. And it worked really well. Patients tolerated it just as they always do. There were nice response rates. It was very durable. And it didn't seem to impact the next platinum. So if in the case of an allergy, I would never use it again. But sometimes you just want to give someone a break, like their bone marrow a break. And this does that. And we haven't studied the sequencing yet, but I really think there's a role for ADCs in the platinum sensitive space in tumors where we don't expect the platinum to be as effective as we would in a historically platinum sensitive population. So more to come. We need to do some studies with comparator arms next.
Yeah, I love that idea. All right, I'm going to give this one to Ritu. 67-year-old patient with ovarian cancer and a germline BRCA1 mutation, had a surgical resection, carboplatin paclitaxel, niraparib maintenance, but with disease progression 1 year into maintenance, 2 subsequent lines of platinum therapy with responses lasting 10 and 7 months, and FR alpha positive. What would you recommend next?
Well, I think we've already talked about it. I think mirvetuximab is a clear answer here. And if there's a clinical trial with it, that would also be an option. But I would definitely favor mirvetuximab or a clinical trial that's kind of exploiting that FR alpha positivity.
Yeah. I think the other thing we're getting into is HER2 testing. FR alpha testing and HER2. And it sounds like you get all of this right up front
Typically.
with your patient. Mm-hmm. Shannon, do you think HER2 should be tested in all patients? And do you test the initial tumor or do you get a new biopsy? And how do you test? Do you use IHC or NGS?
Yeah, I mean, I think we should be testing HER2 in all patients. We typically use an immunohistochemical or protein testing, and you can do that fairly inexpensively. Like, we do it internally at our organization, but there are lots of commercially available tests that you can utilize. I think the main thing is making sure that if you're using one of those tests, that you're not looking at an amplification result and making sure you're truly looking at protein. Because previously, when we were dealing with drugs like trastuzumab, we were looking at either a 3+ protein result or 2+ with amplification, but that's no longer the case. Now we know any protein expression could potentially be beneficial for drugs like trastuzumab deruxtecan. So I do test for everybody. I test whatever I've got. If I've got the most recent biopsy, I'll test that. I don't know if we have a lot of data on the change in HER2 expression after lines of therapy, so I don't know how much that might be impacted by prior chemo and things like that. But in general, if I've got more recent tissue, I'm going to test that if it's feasible.
Now, I know I have a hard stop in 8 seconds, but we got to do this last question because this is really important. In a patient who has recurrent ovarian cancer that's HER2 positive and expresses FR alpha, which we talked about, there's some patients out there, what would you pick, MIRV or TDXD? And we'll just go down the line. I'm going to start with Ritu. What would you pick?
Yeah, I may be the outlier here. I'd probably do MIRV first, just because there's phase 3 data and I like it. And I think that it's sequence. I would use trastuzumab deruxtecan as my next option.
Got it. Katie?
I don't disagree with that, but I would just probably talk to the patient about both risks and benefits, and it'd be shared decision making. I am suspicious that.
Of course,
I know that. I think I know.
Now I look like a jerk.
I would talk to my patient.
Katie actually asks the patient.
I don't know what you do, but I talk to my patient. No, I'm just kidding. I'm just kidding. I'm totally kidding. I am suspicious though to what you just said that folate first, then a microtubule toxin, then a camptothecin. I have this suspicion that sequence may matter, but I don't know that that's true.
More to come, right? Shannon, what about you?
I use the overall survival data, so I would typically give MIRV first.
We are in agreement.
What?
Wow.
But I think, as we get more data, it'll be interesting. I think we've got better data around trastuzumab deruxtecan that it doesn't matter how late you give it, right? You can give it like 4th, 5th line. Those patients still get benefit. I know I had a patient that had like 9 lines of therapy and had a CR to TDXD. So I feel like MIRV earlier.
All right. Well, there you go, everybody. Now everything's answered. You know how to treat your patient. All right, Katie, come on up.
Okay.
Yeah.
Alrighty. So let's talk about some things that are not yet FDA approved. We're going to spend the majority of my time, but not all, talking about antibody-drug conjugates, just to build on what Angeles just reviewed. I think all of you know this, and this is an amazing review for those of you that are interested in amazing reviews. There are almost 200 antibody-drug conjugates in clinical development right now across solid and hematologic malignancies. So when we think about sort of what's hot in oncology, this is it. And why is because what we've been talking about. They work really well. And so we're pretty motivated to figure out how to best utilize these for our patients. When we think about G1 oncology so far, but it's going to change. Probably my next meeting, I'll say there's 3 classes, but so far we have 2 payloads that are kind of used most commonly in the ADCs that are of interest in GYN. First are microtubule toxins. DM4, MMAE are the most common. And then the second, this big peak, are the camptothecins. Topoisomerase 1 inhibitors is kind of the other name for that. So we're going to talk the most about these. But before, I just want to kind of set the stage for what we're thinking about when we think about antibody-drug conjugates, because there's so many, and they're working quite well. Tons of targets, multiple payloads, and so it's really time now, even though the data is kind of early, to be thinking about our strategy. How are we going to develop these? What's the safety? Not just while I'm getting the ADC, but next. Like, what's the long-term impact on the patient for having received these antibody-drug conjugates? And then you've heard us talking about this. Sequencing is important. We just don't understand what the sequence is, but we anticipate that sequencing is going to be important. And so when we break it down, like, what are the areas where we really need to be thinking and working? and it's biomarkers. We've been talking about, this one right here has been talking about biomarkers for as long as I've been a GYN oncologist, because she's like 1 year older than me. And we just haven't gotten it, like biomarkers for bevacizumab. You've worked on that your whole career, Angeles.
Yeah,
Biomarkers still am.
Yeah.
And it's just been elusive, but here's a place where we can figure it out. We need to validate predictive biomarkers, utilizing this sort of spray and pray strategy for just hitting every patient with a TROP2 or a folate and just seeing what sticks isn't probably the best way to develop these medications in a patient-centered way. We really need to be streamlining testing, prioritize our identified targets, and understand, and you heard us reference this, what's the spatial heterogeneity of these targets? What's the temporal heterogeneity of these targets? And mechanisms of resistance and how I test for that is going to be really important when I think about sequencing. Do I sequence 2 folate drugs? Or do I use 1 folate and I never use folate again? I don't know, but I need to figure it out because the drugs are coming. Safety is really critical here. And so we talk, and when we're developing medications, we talk about dose optimization, which is really important, that we move the right dose into these phase 3 studies. We tend to overshoot and bring in too toxic doses, into these phase 3 studies, and then we're kind of figuring it out on the back end what we really want to do. Lenvatinib is a great example, of that. But it's not just the dose, it's the regimen. Am I just using all of these in a platinum-resistant setting? No. I want to move them up. I want to use them as maintenance. Maybe I want to use them instead of platinum. We talked about that. Do I just use them forever? Hey, you're going to be on this with your platinum-sensitive disease until you progress. Maybe that's true. Or maybe it's not true. If I get CRs, do I get to discontinue medications for patients? And how do I assess that? Optimization of maintenance of regimen is really, really key. And designing these studies to be really patient-centered around the safety is going to be a big opportunity for us to do better. And then the if and how of sequencing. And again, we've been talking about this. If we can sequence, how do I sequence? My kind of example right now is with folate. If I use mirvetuximab first, then I kill off the folate receptor high cells and probably some of the mediums, is what grows back folate low? I don't know. I have no idea. But then can I use Rinatibart or Biothera's drug or Zymeworks drug? There's a number of them. Can I use that as a camptothecin to come in, and will it work as well as if I did the reverse? Or does the mechanism of resistance have nothing to do with the folate receptor alpha, and it all has to do with resistance to the payload? We don't know enough to figure out the sequencing, and we're going to need to put these studies together, especially as we move things into the maintenance, to know what to use next and whether I need an intervening therapy before I use another antibody drug conjugate. It's exciting times, but also a little daunting to really move these active, important medications into the right space for our patients to help them live longer. So my assumption right now, and that's why I have that up here, is that patients are going to receive 1 microtubule inhibitor, and I might be wrong about that, and 1 camptothecin ADC. I'm just making an assumption. So what would that look like? We have these two classes. Well, I'm going to use the microtubule example. So one of the medications that's just entered phase 2 testing is TORL-123. It's an antibody drug conjugate. It's actually an academically produced antibody drug conjugate, Dr. Slayman's lab. This is led by Gottfried Koneski, so I'm really proud of this one. This is one of the few examples of drugs that are kind of made by our people. But it's working. It targets Claudin-6, which is a lineage marker, and it has an MMAE payload. And in Claudin-6 positive tumors, the response rate, at least as was presented at ESMO, is 50%. So that's pretty exciting. And you just heard about mirvetuximab from Angeles. So what does this look like? And I'm really proud of this figure. I made this. It took me a long time. I know it doesn't look like it. So, but it really did. It took me a long time. So yellow is folate receptor alpha high, purple is high and medium, green is all folate receptor positive, and then Claudin-6 is any Claudin-6. It's pretty common, it's 85%. But they're selecting, and we don't know the IHC overlap yet, but it looks based like on mRNA that they're almost mutually exclusive. Claudin-6 in blue, yellow is folate receptor alpha high. So these may be mutually exclusive in 2 populations And so your folate, you get MERV, your Claudin 6 positive, you get TORL 1, 2, 3. That would be kind of an easy way to sequence these, because you wouldn't sequence them necessarily. But once we do the immunohistochemistry, this is just an extreme example, what if it completely overlaps? It won't, but it might overlap a little bit. Then how am I going to sequence these 2 microtubule toxins? And again, I made the assumption that I can only use one, but MMAE may be a more potent payload than DM4, so maybe I can still sequence those. So we may have 2 medications in this space with microtubule toxins that we're going to have to sort out the who, what, and where of how we're using them. And this is in a phase 2 trial now, which is pretty exciting. The scenario gets even more complex with the camptothecins, and I just don't have time to do a recitation of all of the data. So I gave you just 4 examples, starting at the upper left and then clockwise. It's raludotatug deruxtecan targeting cadherin 6, and then over to sacituzumab tirumatican, that's a TROP2. IDA191 is a HER2, a novel HER2, and then, I'm sorry, the first one was Renatibart. The bottom left is raludotatug. I can't see without my glasses. But the point is, all the waterfall plots look really good. They look like 40 to 50% response rates. These are pretty nice signals. I'm just going to talk in detail a little bit about raludotatug deruxtecan. This is targeting cadherin 6, camptothecin payload, a deruxtecan payload with a drug-antibody ratio of 8. You'll see updated data on this coming at some point in the near future. This is data that I was able to present last year with the response rate was close to 50% in all comers. The biomarker work is still being done. Median duration of response was 11 months, median PFS 8 months in a platinum-resistant population. So a really nice signal and a nice signal of safety. We did have, if you look on the right-hand side of this slide, this is sort of classic safety around deruxtecan payloads. Common, but mitigatable, if that's a word, GI toxicity and hematologic toxicity. We do see pneumonitis with deruxtecan payloads, but the dose is currently being optimized in this study. And I think you'll see data for this coming soon. 3 doses, dose optimization to really move the right dose, the safest dose with low levels of very low-grade pneumonitis and manageable GI and hematologic toxicity into what will be a definitive phase 3 study, and this is REJOICE-01. And so what does the world look like if I have all these, what if all these camptothecin ADCs, make it? Well, what if I'm down here where the red triangle is and I have a patient who's Claudin, folate, HER2 positive to some degree, 2 plus folate, 1 plus HER2, a little bit of Claudin, a little bit of cadherin. What are you going to do with that patient? How are you going to pick which one of these active medications works best for her at that time, or this person with a different menagerie of biomarkers? We have a lot to learn here. And then we talked a little bit about moving these into the platinum-sensitive space, and this is data from ESMO, where for sacituzumab tirumatican and datopotamab, which are both TROP2 ADCs, there are a few patients who are platinum-sensitive included on those studies, 5 and 9 patients, small numbers, but the response rates are over 60%. And then, of course, you just heard from Angeles about Piccolo, 79 patients, response rate of, I didn't tell you, over 52%. So that looks nice and makes us start thinking about moving things in the front line. And Angeles showed you this slide. I'm just going to make a different point about it. This is from Korea. We need to repeat this here. So this is frontline overlaying BRCA, homologous recombination deficiency, folate, and HER2. And so the notable things are we do have overlap between folate and HER2, but the HER2, if you'd asked me, where does HER2 live, I would have said, oh, it must be HRD test negative. But in Korea, at least, it's mostly in HRD test positive. So we have to see what it looks like in a US-like population. And Angeles is absolutely right. If you look at the bottom Kaplan-Meier curves in the middle, that is the BRCA HRD, BRCA folate, BRCA HR HER2 positive, I am struggling, is green. The red is HER2 negative. And so we've known for a long time that HER2 is prognostic. What we don't know is if these patients got a PARP. They probably didn't, because it was older data. So if they'd gotten a PARP, would this have looked different? And are these the patients who get a PARP and recur during the PARP? I would like to know that, because then you're absolutely right. Do I use HER2 with a PARP? That might be kind of toxic. Do I use it instead of a PARP? And so I'm just going to end by talking about two studies, because I know I'm 12 seconds over. Two studies that are in immunotherapy, because we've been kind of negative about immunotherapy today. So I'm going to end on a positive note with next generation immunotherapies. This is nemvaleukin alpha, which is a modified interleukin-2 cytokine. So we've known interleukin-2 to be active for a long time, but also very toxic. So this modification takes away some of the adverse events that we see. And you can see some of the data with the waterfall plot over there on the right from the phase 1, which was a little bit bigger data here. These are patients with ovarian and endometrial cancer in the bubbles. So you can see response rates with durability. This data and the safety data, which is predominantly kind of fevers and chills and things that we see with immunotherapy, predominantly grade 1 and very mitigatable, leads to Artistry 7, which is completed accrual, and we should be seeing results of nemvaleukin plus pembrolizumab as compared to investigator's choice chemotherapy in the near future. And then we have the Ulvavec protocol, which is an oncolytic vaccinia virus. This is another very fascinating next generation immunotherapy, really aiming to do what we've always wanted to do, is turn cold tumors hot. This was led by Dr. Rob Holloway, so you actually can believe the categorization of platinum refractory actually is platinum refractory, with very high response rates when this medication was given with platinum in these platinum-resistant and refractory tumors. Here's the spider plot and the waterfall plot from his work, and that has led to the now open and accruing on-prime study, which is combining one dose of Ulvavec given intraperitoneal with chemotherapy versus chemotherapy alone. And so this is still open and accruing. I would encourage you to consider patients for this, but this may be how we incorporate immunotherapy into ovarian cancer in the future. And with that, I thank you for your attention.
Thank you.
Sorry.
No worries. All right, so thank you so much, Katie, for that. We're gonna just go into the clinical question here. So Shannon, 68-year-old patient with platinum-resistant ovarian cancer, progressed on mirvetuximab, then most recently on single-agent liposomal doxorubicin. She has an excellent performance status. What would you recommend for this patient?
I mean, I think you want to make sure you've tested HER2 in this patient population. And then I think the other thing is there are all these great trials, that we've heard about from everybody that's spoken so far. These are the opportunities of looking at cadherin-6, looking at CLDN6, and really understanding where we might be able to use those strategies. I think especially with a nice PS, that is an ideal patient to get on one of these trials.
Yeah, I agree. And I'm not going to ask what clinical trials you're recommending, because we don't want to be like favoritism at all. I would just say all of them are awesome.
Yay.
So I hope you have them at one of your sites. Katie, you talked a little bit about cadherin-6 and how common it was in the biomarker. I think it was part of your circle. It was a beautiful figure, by the way. You did a great job with that. What was the percentage in terms of the expression?
I mean, we see in about any expression 76-ish% in high-grade serous.
And in terms of the response rate with CDH6 targeting ADCs compared to other ADCs, I think it was pretty striking data in terms of response. I would personally think it's really exciting. Any thoughts there from the group?
No, it looks like it's going to be for all comers. So, I mean, all patients have activity. So I think it's a very promising therapy.
And you're going to be talking about side effects very soon. Do you have any thoughts about the side effect profile with RDXD versus TDXD?
Go ahead.
I haven't used RDXD yet, so I'll defer to you.
I mean, I think they're really similar. The deruxtecan is what's mostly driving the pneumonitis risk, although I would not say it's exclusively deruxtecan. They're really similar. They're highly emetogenic, but we can control it with pre-medications, and then the hematologic toxicity we have to watch for, but neither of these require GCSF. So they're pretty similar in terms of their kind of class effects. There's no eye toxicity or other things that we're seeing.
Okay, so thank you, that's helpful. And then How often do you see relapsed ovarian cancer that has high TMB or MSI high? I suspect this is going to vary on subtypes, but what has been your experience, Shannon?
I mean, I think it's fairly low. I would say less than 5%, but I still think it's worth testing, especially again, if you're using one of the commercial assays where this is included. It's a no-lose situation in that you could potentially identify a population that can benefit to one of those tumor agnostic indications. And yes, I think, single agent checkpoint is indicated in this patient population if you're lucky enough to identify that marker.
I love it that you guys are just moving right into the next question. It's awesome. It's like seamless. Why haven't we seen the same successes with immunotherapy in ovarian cancer that other solid tumor colleagues have? And are there any immunotherapy strategies on the horizon that might be more successful? And I think, Katie, you just went through that beautifully with your presentations of those 2 clinical trials. So, I think it's just wait and see. And I'll just go back to, is there some sort of elusive biomarker in ovarian cancer that can help us identify which patients are going to benefit? Or maybe we don't quite have it right. Maybe an immune checkpoint inhibitor is not enough. You can drive the immunologic cells into the tumor by giving the checkpoint inhibitor, but there's got to be some other key that we need to unlock the whole door. And can you just talk to us a little bit more about how Nevalukin alpha works, Katie?
The IL-2, so it's a modified interleukin-2 agonist. So that's been a known immunotherapy. I think that's what first cured melanoma, back in the day, just by eliciting this massive sort of immune cytokine release into the tumor. But it comes with tremendous risk of kind of cytokine storm, which has limited its use. And so the modification here attenuates the risk of that sort of cytokine storm and localizes the cytokine release just to the tumor where the drug is binding. And then, as you just said, with the combination of pembrolizumab, you're hoping to unblock the block that tumors use to escape immune surveillance. So the hope with the combination is you're going to have multimodal therapy to activate the immune system and maintain the response.
Yeah, we'll see what happens. I'm really excited to see the results of that study. I think before we go on to our next module, I want to back up because we did get some more questions from the audience, so thank you so much for participating. And we're going to go back to this key-link question because somebody asked, will GOG 3036 change first-line therapy in ovarian cancer? What I recall is everyone said resoundingly, no, not right now. Let's wait and see. So we'll just reiterate that. And then what about the platinum-sensitive patient with third-line therapy such as liposomal doxorubicin and carboplatin? Do you still continue bevacizumab in those patients? So let's say you treated bevacizumab frontline and then maybe second line, and now it's third line. They have another recurrence, platinum-sensitive disease. Do you add bev again or no?
I mean, I talk to my patients. I say that.
I feel so sad about that.
I think it's always I like to reuse Bev, and it depends on the clinical situation. I like it as a maintenance strategy. We know these patients are high risk, and so being able to keep something and not being cytotoxic, therapy that has higher or harsher side effects, I do actually like it. I do actually often use it after prior use.
This next question was, tough to stop PARP inhibitors from a patient standpoint? How do you address? I actually don't think it's tough at all. I'm going to turn this over to my panel, but I want to give a huge shout out for Dr. Deb Armstrong. Yay, because you're amazing. I just want to give you that because you gave us, so Dr. Armstrong's incredible. She was my mentor on my first GOG trial, and she walked me all the way through it. So thanks for holding my hand. But she also gave us some really important information from one of the rucaparib trials, which patients who were treated beyond 2 years, I think the MDS rate was 11% there. So for me, I haven't had talk to my patients about that worry about getting AML or MDS. I think it was 11% AML and MDS. And so, by telling them that story, I actually like to stop earlier. All right. Well, on that last question there, we're going to bring up Ritu to talk to us about Module 4, which is incredibly important as we use these drugs and make sure we mitigate the toxicity.
All right. So it's a pleasure to be here. Thank you guys for staying. You've heard about how PARP inhibitors and mirvetuximab have really changed the landscape of ovarian cancer. So I'm going to talk about the toxicities, and we're going to focus on both short and long-term side effects. You heard a little bit about myeloid neoplasm, so we'll talk about that, and how dose modifications and dose interruptions, dose reductions can help us keep these patients on these treatments for a longer period of time. I also want to highlight some unique side effects, particularly with mirvetuximab, and I want to give a shout out to Katie, who shared her slides, some of her slides with me, which were very useful. I think about toxicities like, I live in LA and we just were devastated by the recent wildfires, and the impact on the community was pretty profound. And I think it's important that we know that toxicities of chemotherapy can also have a pretty profound impact. This is a picture of LA, of the Palisades, facing the Palisades from Beverly Hills, and 24 hours later, this is what it looked like. And this is because of good strategy, good multidisciplinary, firemen, resources approach, that it actually cleared it and contained it. And I think we can do the same with toxicity management. So I'm going to just start, and I'm going to go through some of this data pretty quickly because I really want to focus on some of the questions, and I think hearing from the rest of the panel as well. But the overall adverse events of PARP inhibitors, and I'm going to focus on the front line since that's particularly where we're using these PARP inhibitors, there's definitely some class effects, and there are some unique side effects with individual PARPs, but you can see that, when we break it down, we can think about hematologic effects, gastrointestinal effects, and then general effects like fatigue. And these, we see them all. There's no PARP inhibitor that's excluded from any of these side effects, but there are some different strategies, and this is based on some of the pharmacokinetics of how these PARP inhibitors work, the dosing strategies, and then how we manage them is just generally pretty similar. So I'm going to start with the gastrointestinal effects. And I always, think about this where patients are coming off chemotherapy. And I think one thing that I always like to highlight to my patients is after finishing chemotherapy, you don't have to start the PARP inhibitor right away. I usually like them to have a little bit of a break and recover. So, from the trials, it was within 12 weeks. And I usually start around, probably 6 to 12 weeks-ish area. But, let the patient recover from some of these side effects. But you can see nausea was pretty common, whether it was olaparib and bevacizumab, or niraparib. And we saw, high rates of all grades, but grade 3 side effects were actually pretty low in these patients. And partially it's because we figured out good ways to manage nausea for these patients. And same thing with vomiting. So, preemptively giving these patients antiemetics, counseling them on, whether to take it with food or not food, and how to use these. Less commonly, you'll see things like constipation, diarrhea, or abdominal pain, but these are still important symptoms. And nausea and vomiting being the most common, we talked about antiemetics. For olaparib, you want to avoid aprepitant because they can have some interactions. Patients may also have some taste changes, so talking about behavioral modifications. I often have patients keep food diaries and see what kind of upsets their stomach or not, and kind of use that as a guide. And then don't forget about treating dyspepsia. So using H2 antagonists or proton pump inhibitors can also be a benefit for these patients. But I think these are tools that we've been using for years. We just have to kind of remind ourselves to educate the patients as well. And then patient counseling, I always tell my patients sometimes the symptoms are worse at the beginning and they kind of improve over time. So I think that kind of gives them some encouragement. And then if they are using niraparib as single day dosing, it can be taken at night, and that might also help with some of the nausea or vomiting. And then most importantly, rule out other causes. We know ovarian cancer can often impact the peritoneal cavity, so making sure that we've ruled out things like recurrent disease or obstruction, et cetera. And then using dose modifications as necessary. Particularly patients who are going to derive the most benefits are the patients who can stay on effective therapies. So grade 1 and grade 2, oftentimes dose interruptions, and then grade 3 are recurrent dose reductions. And that's kind of a common theme with the PARP inhibitors. Next, fatigue, also commonly seen. I always joke with my patients, I also have grade 3 fatigue on days, but there are ways to manage this. Once again, really important to rule out other causes. Anemia, which can also be associated with PARP inhibitor use, depression, hypothyroidism, and insomnia, which can be a side effect of PARP inhibitors as well. And then you can think of treatment strategies can be non-pharmacologic, behavioral therapy, sleep hygiene, supportive care, exercise, which my patients always roll their eyes at me when I say that, and then pharmacologic. And so you can think about this. And then once again, for grade 1 and grade 2, dose interruptions, and grade 3 are recurrent dose reductions. And then I want to spend a little bit more time on hematologic toxicities because this is something we commonly see with these. And they're listed here, and I apologize I don't have them highlighted. Anemia is something you'll see across the board, and grade 3 anemia, grade 4 anemia is not uncommon, so it is something you want to monitor for. It's a little higher with the niraparib, and particularly the thrombocytopenia, which I'll talk about in a little bit. But there are different strategies to monitoring these. For olaparib, we do monthly labs for the first 12 months, and if they're fine, then you can kind of increase the interval to every 3 months. With niraparib, it's weekly times 4 until they're stable, so you want to make sure their counts are stable, and then you can start going to monthly and then every 3 months. But it's really important to monitor these, and I always call these physician side effects, where we're looking at the labs and having to chase them down, because patients may not have symptoms, but it's important that you keep track of this. Oh, I apologize, I didn't know I had animation here. But it's a core side effect of PARP inhibitors, and it doesn't appear to be cumulative. So it's not that it may get worse over time, but it's important to really start to continue to monitor that throughout their care. Rule out other causes. Transfusions can be a quick fix if you have any acute anemia that requires immediate intervention. And then dose interruptions, and up to 28 days until it's back to grade 1. Dose reduction if it's grade 3 or recurrent. And then I'm going to talk about AML and myeloid neoplasias, but if they're persistently anemic, do consider a referral to a hematologist, because this can be important in this patient's care. And then thrombocytopenia, I just want to highlight this because this is particularly higher with niraparib, and this is why that weekly labs. I've had patients go from like 130 to 4 in a week, so it's really important that you monitor this. And there are some data about individualized starting doses that you can start at. So typical starting dose is 300 milligrams. If the patient has what we kind of affectionately call weights and plates, weights less than 77 kilograms or platelet count less than 150, you can actually start at a dose of 200 milligrams. And they evaluated this prospectively, and it looked like the toxicities were reduced in those rates, but there's still a high rate of dose reductions even with that lower starting dose. And so you've heard about this kind of throughout everybody's talk, and risk of myeloid neoplasms is a real phenomenon. Now that we're limiting PARP inhibitor use, or predominantly limiting it to the front line, you can see that rates are about 1% to 2% with different PARP inhibitors. And I think we were talking about counseling. How do you counsel patients on this, or what do you think about this? And I think it's important to recognize it's not 0% with placebo. We know chemotherapy can also be a risk factor. So I do think it's important we talk to our patients about the risk of AML and why therapy is limited to a certain time frame. And I think we also heard about kind of how those curves taper off, and that can be important because that also supports stopping this therapy. You can see rates are much higher in the platinum-sensitive recurrent phase because these patients have now received platinum and the PARP inhibitors, but it's important to talk to your patients about this. And I won't go over this in too much detail, but there are dose adjustments that are present, but I just want to highlight, with appropriate strategies and management, dose continuation rates are generally pretty low for PARP inhibitors, so we can keep these patients on effective therapies for the necessary time. So I'm going to switch it up now, and we're going to talk about mirvetuximab, and I hate the eye, I hate looking at the eye, so this totally creeps me out. But it is important for this, and this is, part of the activity. It's kind of a little bit of unknown. There are certain ADCs that have eye toxicities, some that don't, but really the uptake, particularly by the limbal cells in the cornea, may help kind of explain why this occurs. That's enough of that slide. So ocular toxicities are real, and with mirvetuximab, you can see here, I put data from both Piccolo and from Mirasol, just because I have my 2 colleagues who presented this data, and you can see that there are some current consistent patterns with blurred visions, keratopathy, and dry eyes. This particularly affects the cornea, so this is something that patients are going to have they're going to be pretty symptomatic for most of these interventions. And so here's kind of a highlighted, so 49% of patients may report visual impairment, and keratopathy, dry eyes are common. Cataracts is I think it's probably more a secondary effect from the steroid eye drops, but patients may also report light sensitivity or eye pain. And it's important to ask the patients about this. So the recommendation or prevention mitigation strategies include a baseline ophthalmology exam, and then at every other cycle until cycle 8, and then you can do it as indicated. I tend to continue it on because of the eye drops. Patients can have increased intraocular pressure or cataract development, so we do continue it. And you can see that there are some eye drops that are used, corticosteroid and lubricating, for mitigation strategies, and this is really important to help kind of reduce some of those visual side effects. And then patients will avoid contacts because that can also irritate the cornea. The median time to onset of these toxicities is typically pretty quick. Usually by cycle 2 or 1.5 months into their therapy, patients may experience this. And this can be manageable with dose modifications. 22% of patients in these studies require dose delay or dose reductions. But what was really impressive is that almost all of the patients, I think all of the patients had reversibility of their eye toxicity to grade 0, grade 1 within a short period of time. And very, very few patients, I think it was like one reported patient, actually discontinued due to ocular events alone. And there was no permanent ocular sequelae. So with appropriate management, counseling, this can be an effective therapy. These will occur. We just need to know how to manage them. And there are other adverse events. So, we talk a lot about the eye toxicities, but some of the things we're seeing, especially as we're using this more like for longer durations, hematologic toxicity and gastrointestinal toxicities are real. And the other one I always like to highlight is peripheral neuropathy. And so this occurred in about 36% of across patients. And you have to remember, some of these patients may have had neuropathy pre-existing. Median onset to neuropathy was pretty short. And same thing, you can withhold the therapy until it's grade 1 or less, or reduce the dose. But if it is severe, you may have to permanently discontinue therapy. Infusion reactions, we don't talk about this. This occurred about 9% of patients. And you can kind of see here about management. This is common. I just want to highlight this. But there are pre-medications that you can use to help reduce infusion reactions. And then pneumonitis occurred in about 10% of patients. And I just want to highlight this because we're seeing this in a lot of the ADCs. It is important to monitor patients' hypoxia, so doing O2 sats, and then assessing for symptoms. Rule out other causes, and if they're asymptomatic, do routine chest imaging. If they're symptomatic, immediate chest imaging. And I would recommend a CT scan. And then you can see the strategies of monitoring these patients, holding therapy if it's, if they're having, and then discontinuation if it's grade 2, 3, or 4. And so, you've heard about the impact of these novel therapies. I think awareness and counseling of the patients, but really following protocol guidelines to help reduce these side effects is really important so we can keep our patients on therapy.
All right, thank you so much, Ritu. That was fantastic. So one of the things that often people will talk about or express concern is what is the impact of a dose reduction on the effectiveness of the PARP inhibitor? For instance, is there a difference whether you have treated the highest dose or you have to do a dose reduction? What are your thoughts on that, Ritu?
Yeah, I think Katie said it well, is we always kind of throw the highest dose at these patients, and maybe instead of looking at maximum tolerated dose, we should think about minimum effective dose. But, there is some prospective data. It's hard to say because you started patients based on the weights and plates, and it looked like the outcomes were generally the same, but whether there's a long-term impact is unclear. So I think it's important to start patients based on their risk profile, so for niraparib, but otherwise I do start patients at the higher dose, and if they need dose reductions, I think they need it. Otherwise, they may have to permanently discontinue a therapy that could have benefit.
Shannon, do you ever preemptively dose reduce a patient who's, I'm going to say seasoned?
No, I don't do it based on age. I think, sometimes if you've got extensive pre-existing toxicity and you think you're going to have trouble giving the patient full dose, you can certainly do that after talking with the patient.
Thank you for that.
I would definitely talk to the patient first. No, but I don't do it just based on age.
And Katie, how often do you see peripheral neuropathy with mirvetuximab? I know Ritu gave a great graph on that.
Are you asking me?
Well, I'm asking Katie, but I know you did. You gave a graph on that, but I know you have had a lot of experience with this drug.
Well, it's in the clinical trial, it was 22% versus in the weekly paclitaxel, which is the most appropriate comparator, it was 28% or 27%. So numerically, it was a little bit lower. Just sort of feeling-wise, it tends to be something that occurs a little bit later and seems to be a little less severe than weekly paclitaxel. But I will caution that that is in a clinical trial population where we excluded really most pre-existing neuropathy. And so in a real-world setting, when you're using this medication, I think we have to really pay attention to what we're going to see in a generalized population. It may be higher and it may be more severe. And so I don't want people to just go, well, Dr. Moore said it's not that much. It may be more. It's probably going to be more.
I feel like that's what I'm seeing in clinic, but I think those patients are coming in and have more
Yeah,
pre-existing
absolutely.
toxicity than the trial. Ritu, I love the table you had of the AML MDS risk with PARP inhibitors, and you just nicely showed that it was really rare in the frontline setting, like 1% to 2%. And then can you just remind us in patients who received PARP inhibitors later on?
Yeah, and so the platinum-sensitive recurrence, it was as high as like 12%, I think 14% if I remember correctly. So it is pretty significant, but remember, and I think we talked about this earlier, is that at that point we were using PARPs until progression or toxicity, so patients were being treated for long durations of therapy, and I think that there is a cumulative effect of that on top of prior platinum-based regimens.
Yeah, and all the data you quoted was like from phase 2 or phase 3 trials, so I thought that was a really nice summary table. So you also addressed this as well in terms of the frequency of ophthalmologic exams and made some really great points, because I've had people tell me, and you taught me something really important today, was that if they're not symptomatic, then, often, for instance, when you have your patient have their exam and they come and see you and they might have this mild changes, but they're not symptomatic, you're not going to change their dose anyway. But you made some really important points about the pressure, the ocular pressure, and the cataracts. Can you expand on that a little bit more?
Yeah, I'm a little sensitive to this because I have a patient who's, I think, on cycle 14 of mirvetuximab, and she has, and I honestly sometimes wonder if patients minimize their symptoms or underreport their symptoms because they're afraid of being taken off therapies. But she had an eye exam and her intraocular pressure was really high, and so we actually had to stop her steroid eye drops. That was the reason why we had to stop her or hold her therapy, which was kind of a little bit of an interesting phenomenon. So I no data to support this, but I'm going to be one who's going to probably continue to promote continued ophthalmology eye exams, because I think it's something that patients may underreport or minimize. I may not be asking the right questions, but I think there's some indirect side effects that aren't necessarily symptomatic.
Shannon, what do you do if you have a patient that does not tolerate one PARP inhibitor due to heme toxicity? Do you switch to another, and is there any clinical evidence supporting that switch?
I'm going to start with the second question. There's very little clinical evidence, and yes, I absolutely do it sometimes. So, I think you start one based on what you think someone's going to tolerate, what's available, cost, schedule. But if you've got a patient that has a very strong biomarker, BRCA positivity, you really want to give them a chance, and you're seeing some hematologic issues, I think it's reasonable to try. And I've got no data to support that, just a sense. A feeling maybe, I don't know. But I do think it's reasonable to try.
I think we've probably all done that. So we've reached consensus a third time. I'm going to move to this next one because I think you did such a great job of answering the follow-up for heme issues. So Katie, patient using mirvetuximab presents with a cough. What are kind of signals for you to know whether this is a cold or is this an early manifestation of pneumonitis?
So the pneumonitis, I think we're still really learning, so I do want to couch this with some caution. The pneumonitis that we saw with mirvetuximab appears to be really distinct from the pneumonitis that we see with TDXD or the deruxtecans, in that, for one, we didn't, this was in the day where we were not really calling it. So you get the CT scan that says inflammatory changes clinically correlate, and I would say, how you feeling? They're like, great, feel great. Okay, so we weren't calling grade 1 pneumonitis, at all. And now we are, because I think we're getting more educated. So the rates are changing some because of the call of these grade 1, which is asymptomatic, ground glass opacities, blah, blah, on the CT scan. The CT read does not tell you, it does not say, hey, early pneumonitis. So if you're expecting that, that's not what's going to happen, which really can be confusing. So I think we probably underreported MIRV. That's my first comment. My second comment is, in the ones where we saw it, if the patients felt fine, we did not hold therapy, nor did we modify therapy. And in all but a handful of cases did it progress to symptomatic. Now, as it's in the real world, and patients may be getting a deruxtecan payload, I think we're going to have to be really cautious about me saying that. So I want to be really cautious. I think I would hold now. I'm a little more cautious.
I think that goes to that next part of that question. Well, number one, I don't I don't think the question here is chest X-ray sufficient for initial evaluation. I would say no.
No.
I would get chest
Yeah.
CT. And then are you monitoring and management algorithms for ILD pneumonitis with MERV and TDXD the same? And TDXD is a lot, like you were alluding to, can be a lot more severe in terms of the pneumonitis.
Well, you hold for the grade 1 with TDXD, even when the drug's working. And someone's like super happy that drug's working and you see a little ground glass thing on their chest CT and you hold them and they get mad at you because they don't want you to hold their medication. They feel fine. Their O2 set's 98%, but you got to hold and work it up. With MERV, currently, we do not have that guideline in there. And that may be okay, but I do think we need to pay attention to this as we get more data and just be a little maybe more cautious than perhaps we were in the past.
I agree. Well, Ritu, you did a great job kind of giving us some information about how to make sure our patients get these drugs in a safe manner so they can truly benefit. And we want to thank all of you for your attention today. We hope that this has been helpful for you. Love your feedback. And feel free to ask us any questions. We hope you have a wonderful day here in Seattle. Safe travels back home on Monday. Don't forget Mopop night tonight. And see you later.